Good morning, colleagues and friends. Greetings from Geneva, greetings from the World Health Organization. Thanks to the organizers for inviting us to contribute to this session. In my brief presentation, I'm going to take you through WHO's guidance on ethical considerations in planning and reviewing recent studies on sexual and reproductive health in adolescents. And after I do so, Dr. Abha Saxena, who till recently led the Ethical Review Committee in WHO Geneva, will speak about the ethical implications of POCSO, the Prevention of Children from Sexual Offences Act, 2012 India, both from the clinical context and from the research context. My next slide highlights the background of the development of the document. This slide is titled The Sexual and Reproductive Health of Young Adolescents in Developing Countries. This is a meeting that took place in 2010 here in Geneva, and at this meeting a decision was made to develop ethical guidelines for research on young adolescents. My next slide is titled Mapping. So in terms of preparatory work, we examined available documents in the public arena. Two of them are listed on this slide, and what was clear was that while the international ethical guidelines for biomedical research involving human subjects mentioned this adolescents, this group was, and their needs were not properly addressed. The next slide is titled Consulting, and what we did was we consulted with a range of stakeholders, a culturally diverse, geographically diverse, and professionally diverse group of stakeholders. And I asked them, what do you think are the important things that need to be addressed? We included both researchers and programmers. And then we identified a short list of things, recognizing that there are many things that need to be addressed, but we chose 4 things to address initially. Dr. Jerome Singh, who is a South African of Indian origin, an ethicist and a lawyer who's been involved in some cutting-edge research, both in South Africa and globally, led the development of this guidance. Now, in terms of content, this guidance addresses 4 issues. And the next slide is titled Section 1. And this slide deals with the study population. It names and defines terms typically used to describe or characterize adolescents, and it explores their legal implications and social connotations. Now, for example, the word teenager is widely used, a term that began in its use in the US, and it has a particular connotation. If you use millennials, it has another connotation. If you use adolescents, it has a different connotation. And not just that, it also, all these terms mean different things. For example, when we say child in the colloquial usage, we think of a young child. But if you use child in the context of the Convention on the Rights of the Child, you mean up to the age of 18. And that has very different implications clinically, legally, and otherwise. So the next slide lists the conclusions in this section. Essentially what it says is, be aware of the different terms used, and the meanings of these terms, the legal implications of these terms, the social connotations of these terms in the local context. We often see research protocols where very different terms are used. And sometimes these terms are contradictory, and at the very least they cause confusion. So the recommendation here is to choose an appropriate term for the study population so that there is no ambiguity, so that it's clear as to who is included and why, and with a full understanding of the implications of the use of the term. And increasingly what we're asking researchers to do is to explain why that term was chosen to describe the group. For example, I was with Dr. Sunil Mehra, I believe he's with you, last month in Lucknow for a meeting organized by Mamta, Sunil Mehra's organization, along with the Gates Foundation and the government of Uttar Pradesh. And in that meeting, it was focused on young parents. Young parents who have few children or no children. Now, terms like that need to be defined. They need to be defined because young can mean different things to different people. And in an initiative, and especially in a research initiative, it's useful to spend half a page defining what we mean by the group, why we are engaged in work in relation to this group. The next slide is really the heart of the document, this one and section 3. But this one is absolutely crucial in any discussion on adolescence. I mean, I believe that most or all of you are pediatricians, and of course you recognize that a child of 12 is very different from a child of 15 or 16, cognitively, emotionally, socially, and so what does it mean for us as a clinician? As of course very important, when you're discussing in the context of the terrible pollution that has been there in Delhi for so many months, and you're talking about asthma in a 13-year-old with the parents, whom do you engage with, how do you engage with the adolescent, what do you talk about with the adolescent, are all issues of, evolving capacity, autonomy, consent, assent, evolving capacity and maturity. So this particular document, this particular section discusses the legal and ethical requirements for obtaining adolescent consent for research, adolescent assent for research, and where waivers can be obtained. And of course, any discussion on consent and assent has to be based on an understanding of adolescent capacity for decision making, adolescent maturity, cognitive maturity for decision making, and what the legal requirements are. All these are wrapped up and need to be teased out. The next slide is titled Section 2, Autonomy, Consent and Assent. And our conclusions here are, first of all, we must understand norms and traditions of decision making. In some cultures, satisfied users of a contraceptive method are engaged to share their satisfaction with others. In other cultures, this would be considered aberrant. So, what are norms in one culture are very different from norms in other cultures. So, understanding the cultural context, understanding, of course, in a country like India, you have many different subcultures, even in one geographic area, that need to be taken into account. We need to learn about informed consent and assent requirements in the legal sphere. And for research involving children, WHO recommends, and I think all research institutions and bodies recommend that informed consent be obtained from a parent, guardian, or a legally recognized alternative, which could be a judge in a particular place. Assent is something that many countries don't ask for. So you get consent and you kind of launch into the study, but the adolescent in a growing number of countries has the ability, is empowered to say no, even if his parents or guardians have given consent for a study. And then there are many situations where waivers can be obtained. You can actually go to an ethics committee and say, on these grounds, we want to seek a waiver. I've shared with Harish Pemdev the electronic copy of the document. I've also sent him 25 hard copies. You can look at all the situations where waivers can be obtained. We don't use waivers enough. We are often intimidated by the consent requirements. But actually there are many very good reasons for seeking waiver. One may be, for instance, when you're surveying young people living on the street and who run away from home, for example. There are very good reasons to seek waiver in that situation if you want to survey them. Similarly, this is geographic. But in another case, you might, if you suspect that the parents have been involved in abuse, you can make the case for waiver. Whether the ethical committee gives it or not is another discussion. Now, I think waiver is very important to ask, even if you're asking information in the context of the survey. When I was in Delhi last month, I spoke to Aparajita Gogoi from the Center for Catalyzing Change. They published two very important studies, what women want and the Youth Bowl Survey, what young people want. And I asked them about their ethical clearance that they obtained for this study. And they were not very clear about that. And I think these are very important issues to be taken into account even when you carry out a survey like this. Moving to the next issue. My next slide moves from the research to the consent for clinical work. This is a paper published by Valentina Baltag and who's a colleague and collaborators in outside WHO. In the UK you have very clear competencies, the Gillick competencies. These competencies have been clearly laid out so that in the law a parent has the right, a health worker has the right to assess competence and provide contraception or provide abortion services without parental consent. In most countries, this is grey. There's no clear guidance. This is something that you as an association can press for. You can first of all develop codes of practice if you have not already done so, excuse me. If you've already done that, excuse me. But this is something that you can, as a group, develop and then press to the government for inclusion so that pediatricians and people who work with adolescents can be empowered in specific situations to engage with the adolescents and make decisions with them about mature minors. Growing numbers of countries are doing that, but they're primarily northern countries. And I think there's a huge body of expertise in India to do this. My next slide is about Section 3. And this is reconciling ethical and legal obligations with regard to adolescent research participants. And of course, at the heart of this, like in the heart of the previous one, was our understanding of maturity, cognitive maturity, social maturity. Here, the heart of this discussion is best interest. What is in the best interest of the child? And when the legal requirements conflicts with the ethical imperative for best interest, what do you do in this situation? Look at this case study. Here, the investigators in a southern African country wanted to do an open label study to evaluate some issues in relation to young men who have sex with men and with transgender women. However, in this case study, they looked at the fact that this is criminalized in this context, and then looking at the considerations discussed in the chapter. In this hypothetical case study, we give a hypothetical response that this is what the researchers did. And in many cases, that's what we need to do. We need to make case-by-case decisions. The next slide talks about essentially this. when faced with a conflict between a legal obligation and an ethical duty, we need to consult with professional bodies and colleagues, make a decision and document that decision so that if necessary it can be held up with an inquiry board or even with a legal entity. And then, of course, what we say is avoid conducting research when the subject matter is unlawful and when participants or study staff could be subjected to criminal sanction. Now, of course, the big problem with this is by saying this, you close the doors in many areas. Let me give you one concrete example. There was a research study in South Africa on sex work. Now, sex work under the age of 18 is illegal. So the research study examined sex work in those who are 18-year-old and more. But at least a good 30% of sex workers are below the age of 18. But because of legal imperatives, legal requirements, they were not examined. So this is very much like, I dropped my keys in the forest when I was going for a walk, but I'm searching for my keys under the lamppost because that's where the light is. We really need to find a way to examine, we need to do research in difficult areas, and we need to find ways to do that, seeking waivers with well-informed and well-engaged ethical committees. And I'll tell you what we're doing in this area in a minute. The next slide is the adolescent job aid that we developed some years ago, and essentially many health workers have to deal with this challenge of what is ethical, what is legal, and what is practical. Like this health worker in this, on the top right of this book says, I want to help this woman, this young woman who's in my clinic, but I don't want to go to jail. What do I do in this context? The last section of the document deals with information sharing. What is our ability to share information? Where do we share information, where do we not? What is a child's right to privacy? How do you balance legal disclosure obligations with what is in best interest? And of course this is important because, I remember my good friend Swati Bhave, I don't know if she's in the audience, telling me once that, the mother says, I don't want to leave the room. You ask the mother, I want to have a private discussion with your daughter. Mother says, I don't want to leave the room. I'm the one who's paying the bill. I will sit here and you bloody well talk to me as well. What do you do in these kinds of situations in the clinical context and in the research context? How do you respect the child's right to share information and to be informed? And of course, growing up in India, being Indian, and now having lived in Europe for 25 years, we have a very different cultural context in terms of sharing information with the parent. Here in Europe, the doctor shares all the information and says, it's your information, it's your life, you deal with it. And even now dealing with so many relatives in India, all the discussion is, oh, don't tell them, they don't want to know, they'll be shocked. And of course this is culture. But there's also a legal imperative on what we are required to share. So respect a child's right to share and to be informed, respect a child's right to privacy and obtaining their consent before sharing information, and balancing these rights with judicial directives on obligations to share. And that brings us squarely into the discussion of POCSO. So what we've been doing since we published this document is we have engaged with WHO's Ethical Review Committee. We want to develop a set of training materials that WHO's Ethical Review Committee and UNICEF's Ethical Review Committee will make available to research institutions and researchers all over the world. But in order to do some groundwork and get some feedback from countries, we had a workshop in Mumbai last year. In December, Abbas Saxena was going to speak in a few minutes, was part of that workshop. One of the people led the workshop. We're going to have a similar workshop in Kenya in April and one in Peru in November, and use this learning to say what do people on the ground say in terms of what needs to be done. I'm going to stop here and hand over to Dr. Abba Saxena, who is retired WHO colleague who's worked in Delhi for many, many years, who will speak to the implications of POXO and maybe go on to other things depending on the time available. Over to you, Harish, and over to you, Abba. Thank you all.